Good morning and welcome to our monthly webcast. I'm Samir Mehta, your moderator. This is session number 161. Welcome to all of you from a beautiful morning in New York City. We have an exceptional teaching case for you as per your request. When you have sought more and more chronic total occlusions. So here is another of that. We'll take you through the motions, what should be the right approach, guide you with the app, whether it should be antegrade, our preferred approach, or is it something which is going to require a retrograde approach. With this introduction, let me take you to the cardiovascular laboratory where Dr. Sharma and Dr. Kinney are standing by. Anu, good morning. Samin, good morning. Glad we have another CTO case today.
Yes. Maybe we can put a camera a little better so everybody staff. So the good morning and welcome to our CCC live viewers globally. And this continues to have a lot of requests about the CTOs, both antegrade and retrograde. Everybody should come on this side so that we can see in the camera. Yeah, good. So key is that looks like that we had taught the entire world about the bifurcation, rotablation, calcification. They want to go to the next frontier, and our goal will be in next few months that try to explore and show various kinds of CTOs. So that is the goal today. As you saw that case number 161, we welcome myself and Dr. Kinney and the Cath Lab of Mount Sinai. All the common faces which you see most of the time are consistently part of CCC live journey, along with our two fellows. Here is Richard and Vishal. So both of them, and then rest of our staff, including imaging expert and our same cardiovascular technician and our nurses. So with that note, we start this case. Let's start our presentation, please. So this is nothing new. Case number 161. Little interesting in the sense that's probably one of the youngest we have done in our case series of lives. It's a 37-year-old without any prior history, was admitted to outside hospital with class 4 angina. Have 3 vessel disease. They recommended CABG, but because of age, he declined and came to us and had a PCI. Only risk factor basically was he was a smoker and had high lipids, and the EF was normal or normal even now. And patient was put on various medical therapy, including, you can see, dual anti-ischemic therapy. And cath done was 3 vessel disease. And we showed that angiogram now. At that time, some of the vessels have been taken care already. Anu?
So this is a LV gram. EDP was normal LV function. And we are going for this picture of a dual. I'll show you what we see otherwise. So he had LAD as well as Ramus, which we took care at one sitting, and he had this totally occluded RCA. So it's a distal RCA occluded. When he first came to us, we had good, the first septal connection was there, but since we have had the intervention of the LAD and as well as the Ramus there, we do not see it anymore. But this is where we are. So he has distal LAD moderate disease, but otherwise the stents that we have done looks good.
Yeah. So he basically, the circumflex was CTO, distal CTO, then there was Ramus/OM, was 95%, 99% got a stent, and there was a LAD lesion, got a stent. There was a moderate diagonal and distal LAD lesion, which you can see. But RCA is the culprit now with a total occlusion, which fills. We have both bridge, collaterals, as well as the retrograde collaterals. And there seems to be a good channel at one point from the septal down into the PDA. So you want to emphasize on that? Question is antegrade versus retrograde, yeah.
So here we are, the first septal. We still probably there is some kind of a connection from septal to septal of the PDA, which you can see. This is the best we have here. Otherwise, we have this antegrade channel here. So there is a moderate disease in the proximal RCAs. Since it was distal RCA, normally you don't see us using the AL guide, but since it's CTO, we said, and some moderate disease, we still used AL 0.75 guide with side hose.
And guide is really, it's a good guide support. Little bit of lesion at the ostium,
Yeah.
tip of the guide, was mild disease all the time, but there is a good segment, about 30 millimeter segment of the distal RCA, totally occluded, filling by various collaterals. So as you
Samir,
know,
and
yeah.
significantly without much calcification.
Yeah, that is true. Young person, no diabetes. Particularly no renal failure issues. So all were soft lesions. Even circumflex was soft when intervention was done. No atherectomy or atherotomy was needed when PCI was done of the LAD, ramus OM, and distal circ. So this is here also no calcium. And now always question comes, this type of case, let's see just 1 second. Let's complete my presentation. Go back to the slides, please. So this patient declined largely because of age. High syntax score of 33, but then has PCI of the LAD, OM, and CTO with the Promus DES. Now, question always comes. CTO, as you know, with the newer guidelines, is a 2B. That patient has to be symptomatic or ischemic. Question comes, if you decided the complete revascularization in this young patient, who would have gone for CABG, of all the vessels, including the CTO, once you decide for PCI, we also know the data, long-term data of PCI is equal to or approaches similar to CABG. In this particular case, young person, we are talking about not acute success, 5, 10, 20 years. So is the complete revascularization. So I would say in this particular case, even if patient is asymptomatic, the CTO PCI is a part of the initial revascularization. If let's say we would have done at time 0, which will require more procedure time, more contrast and radiation and so we decided to stage it. So it's appropriate from that point of view, and that is what we are going to do today. As a complete revascularization using antegrade approach, and if fails, then retrograde, as Anu pointed out, there is a septal collaterals. So basically, it's a 2-vessel disease. This patient, no stress test has been done, was admitted with rest angina. There was some question when last month when they admitted to outside hospital, troponin were borderline. So by definition, it was a unstable angina. No stress tests were done. Cath was done, which revealed those multi-vessel disease. So in this case, we felt that it's on anti-ischemic therapy is appropriate to go with the PCI. So Anu, tell us what's your plan now.
So we have
All right, guys, come
LAO.
in. Yep.
Yeah, this is where we are, and I think we'll start. Our microcatheter we are using is fine cross.
Anu,
And fielder,
in the
we could
meantime,
use any microcatheter. Yeah.
before you go to the microcatheters and the wire, there are 2 questions coming in regarding the approach you're using and which guiding catheters do you prefer?
So we already mentioned it's a distal RCA. So we do have AL 0.75. So we have a good guide support. Other catheters, can you use hockey stick? Yes. Lima guide? Yes. Akari guide? Yes. So any of those. So we have a marked guide right now here, but even the Medtronic AL 0.75 would be a good support. Then going to the mic of the which we definitely we teach, we will try antegrade first with a soft tip wire, and then we will gradually escalate with the other wires, and we will discuss the wires as we are going through. Then microcatheter, again, so we are using fine cross, but you could use a Corsair or Turnpike, whatever people are comfortable with.
And other question comes is, should you have gone with the left-sided guide also, in case you fail with the right, go with the retrograde collaterals, retrograde injection.
We have a long sheet, just we didn't go with the guide.
But 6 French.
Still, 6 French, we are always worried about dye use, so try to minimize the dye load.
So basically, if you need to, you will upgrade, you change the guide on the left side if we cannot succeed antegrade, correct?
Yes.
So therefore 6 French sheath is there, so we don't have to worry about increasing the sheath size. It's only changing the guide will be. And we all know that the guides are definitely more obstructive to the vessel compared to your 5 French diagnostic. So if not necessary, not needed, you don't need to. The dampening is a common phenomena in the occlusion, as you can see here. Despite the side hole in this AL 0.75, when to put a hemodynamics below, please, there is a dampening of the pressure on the right side.
So, I mean, when this patient was being discussed with the heart team and the surgeons, I'm sure he was offered a complete arterial uh, bypass as a solution.
Absolutely, that is correct. Yes. So that was the one of the point was in this particular case, complete revascularization including arterial, and this is what actually in our system here we have few of our cardiac thoracic surgical colleagues who will do a total arterial revascularization considering
Give me
his
the
age,
miracle.
both
So,
lima, rima, and radial. So we'll get at least
Absolutely.
4 or 5 bypass with a lima, rima, radial. Yes.
no, miracle 6.
Okay.
So here there's a small side branch that you can see in the original picture, and I think my fielder just keeps going.
Hmm.
You see that? So if you take the JCTO score, other than the length, most of the other things are favorable.
Yep.
It's a tapered, but there's this small side, a branch. My fielder is just keeps going into that. Now, this is what I meant. Now you want to go to pilot versus you want to try fielder XT, A, or miracle is up to. These are the various choices. Any of these wires can be done. So small curve, if you can see here from the ceiling camera.
And what are
Anybody
you
can
trying
see.
this time now? What
This
is
we
this
are
wire?
using miracle 6.
Yeah, Miracle 6 is the second wire escalation.
Yeah.
Good. Okay.
Now, if they want Gaia, probably
The
okay.
other
But
question
I think
is, yeah,
soft
keep
tip
this.
fielder family probably would be the next bet. Pilot versus fielder
Okay.
XTA. Don't give die.
Okay. So you have gone beyond the side branch. Yeah.
Now I have to get into this. So I'm going to pull back the micro catheter a little bit and try to engage.
And this patient is on Plavix because of CTO. We try not to give more stronger P2Y12 agents if CTO working because they have more chance of wire perforations and so. So then we use the PRU. So PRU has been done and it's 119. So anything less than 230 is good. So we don't need to change it. Although I would definitely, my personal inclination would be change it to a pressagral after we successfully recanalize the RCA CTO. But want to leave it clopidogrel is completely okay also.
Now you see that I'm trying to advance, and this wire is just making the turn into the side branch. So we have to decide now that should we go with the aggressive wire right now. See that? Are you able to appreciate that?
Yes.
I'm getting into the side branch. Yeah.
Yes.
So I think I would
So,
go
I mean,
to
what about
Confianza
the
now.
anticoagulant strategy?
Yeah.
We have Angiomax with the ACT about 285. Yeah.
Yeah.
Now,
So
some
question
sites,
comes, a
some
lot of
sites,
people will, yeah,
right.
lot of people will be worried about giving Angiomax in terms of not reversing it. And I can tell you, we actually published our paper with a wire perforation.
9.
So they did better with bivalvulotin versus heparin. Because heparin, you have to reverse it and all
Can you
those
take a
issues
picture?
taken together. So
Antegrade.
we actually routinely use bivalvulotin, but yes, people who are concerned, they want to go with the heparin, that's okay too.
I don't know. You wanted to try Gaia here?
But we have no hesitation because we have seen that is the wire perforation somehow do better when you talk about bivalvulotin compared to heparin. Now, why that is still unclear. No, part of that is, remember the half-life of 22 minutes of the bivalvulotin. After 50 minutes, everything is good. Let's go retrograde a little bit. And compared to heparin, you always have to undo it, reverse it. And reversing caused the trouble. So you see the wire has gone reasonably well in one of the distal.
Somewhere there it has gone.
Yeah, yeah.
Into,
I just had to make it to the one of the branch.
this is the Gaia.
This is the Miracle 6.
Miracle 6. Okay, we
6.
didn't change to Gaia.
No, Miracles. The question was Andu was saying that want to go to Gaia 3, that's okay. Some want to go to Pilot 200, that's okay. Another one would be maybe Confianza 9, people want to go, that's okay. But I think this one would not have been the Fielder XT, A or so, because those are very thin wires.
Right. This is definitely a more promising Samin, you anticipated
Now done.
two questions
That's
which
it.
came. Okay, there we go. I think we are
Let's see where we are. No,
just the way it went. It had a looks all
yeah,
right.
good. Yep,
All
looks very
right.
good. Yeah, exchange length. So now we are advancing.
Yeah, if you can see my wire of so hand movements
Yep,
here, are
seeing
you
it. Yeah,
able
yep,
to see
yep,
that?
yeah.
How I am
Pull the wire
advancing?
back. Yeah,
Can you focus on my hands
yeah, yeah.
with the
The
ceiling
shrink.
camera?
Yep.
Yeah, good.
Good. Now this our fine cross has been advanced through the lesion distally, and now we are going to just change it to the exchange length wire,
Give me
and
the
then what do you
needle.
want to 20
Needle.
2020?
2.5. Once this goes, we can go
No,
with that.
2020, 2020. Go with the compliant. So we need to open, and then we have to get to the branch. Remember, we had to get to the PDA. So in this case, we had to save the PDA because PDA is very important, more important than we know with the posterolaterals. Uh, so even if we have gone and opened the posterolateral, we'll still go and open in the, yeah, good, in the PDA.
I want to show one important point here. So did mention we wanted to change, right?
Yes.
I didn't see it. No, hold on.
Yes.
Yeah, this is where we are. So that wire initially was going to the small branch. So since we have the tapered proximal cap, it was very important. See how the wire was facing. I took the cine. You can see that. After this, we were able to navigate through that CTO. It's very important point.
Yes.
One, or if this would not have happened, then we wanted to change the wire. Then that's what we were talking. The Gaia means anybody wants to go to Gaia is okay, but I would wanted to go to Confianza 9.
So we can maybe have a little discussion about escalation of wire in the CTOs. So right now we are in the large posterolateral. The guide is a little too far in, but we'll push the guide out now. We are going with the 2020.
Andrew,
just do a
can you
Fogarty
show
and take
that
a
wire
picture?
escalation slide? Yeah.
Fogarty and then come out. Yeah, let's
So we
take a
can
picture.
take a picture,
Yeah,
yeah.
yeah.
So
Okay,
this
see,
is
I always say in CTO, you take a little picture after your Fogarty, so you know that you're not wire not gone to the side branch.
Still not able to see it. So
Huh?
what we can actually do is when you
Control
are
it,
there,
yeah.
you can go give retrograde
Yeah,
so that
floor
you
up.
are just at the bifurcation and not going distally. Yeah, right
Yeah,
there.
good.
You can
Yeah.
dilate here. You see that?
Yep.
Because there's no lesion after that.
You know, sometimes
Get the
maybe
fielder ready.
it is a good idea to struggle a lot more. There is a comment here I cannot make out from where.
Down.
It's either from probably from Greece. I think it's not a true CTO because the wire went so easily.
Well, that's not
the technique and using exactly the right wire. There's a 30 millimeter long CTO. Of course, as Dr. Kinney mentioned, with the low JCTO score.
Yeah.
Ready?
1 second. Yeah. Good. So that part is done. But now we have to go with the fielder wire into the PDA. See that? PDA is a big vessel which has become subtotal now. So question is CTO by definition more than 3 months, which is this particular case which we know for sure. Yes, we have a favorable JCTO score. Length, yes, not a calcification. There's a tapered tip and the
But there
bend.
was a side branch there.
Yeah.
Yeah. No angulation, but side branch. So we could have CTO score of 2. Yeah, good. Now,
So anything
you
is,
wanted us to do that?
yeah,
or
no PDA. No, we have to do a PDA.
Picture and place a stent at the.
No, but you have to open the PDA ostium. You see now, Yeah, get the filter wire. See this now.
Go that easy.
Because you need to take care of the PDA ostium before you put a stent. There was a disease in the AV continuation quite a bit.
No, it's really quite amazing. Relatively, not even relatively, such a young patient with such
Yeah.
aggressive disease.
Disease.
And,
Yep. Look at this one.
This is a kind of a patient you see in India all the time.
Yeah. AV continuation after PDA has definitely a moderate lesion. See that? Your stent, you have to put it across unless you want to do a step crush or so.
Nothing.
Yeah. But anyway, let's open the PDA ostium because there is a disease.
This is a young guy. You don't know how he's behaving to multiple stents. We
Yeah.
could leave it just before the bifurcation.
That is true. As long as we
leave
can
it alone.
open a little bit there. Yes.
In the meantime, we have the CTO wire escalation strategy from the app.
This is why I didn't want it. Remember, it was dissection there, and we may not be going.
Okay. What do you want to do now?
Get me a run-through wire. That wire was gone. And dissect the whole thing. Just stand it. Run through.
So tell us what you are doing now.
What ideally I would do is just place a stent before the bifurcation. No matter, it was a chronic lesion. You see that the way the wire, the wire is even now behaving like there is some calcium there when I'm trying to wire with the fielder. So I'm going to a run-through wire to go through that lesion.
Ostium.
Because
So question is, if you put a stent just before, remember there may be an issue in terms of landing exactly at the bifurcation.
No, you can use the retrograde
Understood.
angio
Yeah,
and
yeah.
then place it at
Right.
the bifurcation.
No, that is true. So then, but question is, if there is a little bit of ostial pinch, will be more troublesome. If we can get through a little bit here, we try. Otherwise, no.
You can wire afterwards.
Okay, let's get a Promus then. 2.5 will be okay.
2.5? It's a big vessel.
2.75,
3 or
3
or
But it has
2.75. Okay.
275, 32. 32. Okay, now this is a run-through wire. Try not to go through any dissected channels. If there is a question, you always go, put a stent and then try to go into the PDA after that. Want to go epicranial?
No. Give me retrograde dye so you know we're going into the PDA.
So just when the previous viewer had observed, it is too easy, the CTO, now you'll realize how challenging it is.
Bifurcation. No, it clearly was by retrograde injections was bifurcation. So it's not only just doing the vessel, you have to keep all the vessels patent. That's our goal, and particularly in young person. And that is why we are against the retrograde, because retrograde traditionally clips off many branches. And that is, studies also have shown all those retrograde dissections have higher total occlusion and restenosis. So we try to avoid that.
This may require.
Yeah, it may require a little stiffer wire.
Yeah, that's what. So I think why don't we just stand proximally?
Okay,
and
let's put a
then
stent
take,
first. Yeah.
Other wires to go here.
Okay.
Once we start, we may.
You can leave it in the aorta, this one.
Yeah.
Good.
So what length you took? 32?
Yeah. Yeah.
Okay.
Good. So we are putting the Promus. Yeah.
Just a reminder for the viewers that all the downloads of the apps are free. So take advantage of that and
the bifurcation 3D actually app, Bifurcate 3D has received a lot of downloads, right? It's one of the most popular one.
No, the most popular is the original bifurcate, which we
Bifurcate
are
is-
upgrading it right now.
Yeah.
I thought the ones with the complicate was also doing very well.
On the website.
That's just on the website,
website.
but it's doing
And,
good. Yeah.
In the meantime, I want to, today we have many, many viewers actually from Pakistan and from Jordan.
Ready?
Yeah.
Okay.
Retrograde,
Welcome
yeah.
to all of you, and
Okay.
the audience in
Good.
What do you think?
Pakistan. I'm
Yeah.
sure you have all enjoyed the T20 World Cup and the
There's some die
exceptional
retrograde.
performance there.
Except the finals.
Yes,
There's some die.
even that turned out to be a very close match despite the low total
Good.
they were
No,
chasing.
no.
But
I want to take another cine.
Yep. Yeah.
What do you think?
all I can tell you is that
Go in.
often you put in
Yep. 1 millimeter.
the viewing from the
Some die?
retrograde is the one giving most information.
Yeah, some die. Yeah.
Yep.
Yeah. Okay, good.
Precisely.
Go up. Yeah.
Yeah. Okay.
Okay, good. Down.
Pull your guide back out a little bit.
Okay. You want to place a stent here. That's okay.
The
You can
guide
have-
keeps getting sucked in deeper and
Yeah.
deeper.
We are going to stent that lesion while coming out. Yeah.
Yeah. There was
Now,
about 30% lesion there, 30,
Where's
50.
my
Yeah.
miracle? Is still good, or we need a new one?
Yeah.
Get me the fine cross and miracle, and then I may need that to go into the side branch. Okay, ready? Let's take a picture. Antegrade now.
Yeah.
A lot of work still needs to be done there.
Yeah.
Okay. What is the strategy now?
I'll go with the fine cross and try to get into the PDA.
So a little modification in the lesion you were approaching. It is a CTO bifurcation rather than just a CTO.
Yes.
CTO bifurcation in a young 37-year-old.
Keep this one.
No. You know what? Let me do one thing.
That's the stent balloon. You can throw that away.
Really, if to been thinking about this 37-year-old with multiple stents, still areas of the vessels which have lingering disease, he needs a very aggressive lifestyle modification. And
You want to give me a 2O balloon? Maybe
Yeah.
this is facing there.
Yeah.
Maybe just with the balloon I can, right?
Yeah. Yep.
2 or 12 balloon?
Yeah. We have it.
Track? Yeah.
Okay. Yeah. No. Do you know the LDLs and all that today? Have you see it? How things are. So we do measure the CRPs and LDL and of course the A1C in the diabetic patients, and that has led to our multiple publications in the European Heart Journal, JACC interventions and so. So this patient fasting, we send all those. Now recently the LP little a is becoming a new kid on the block, and we are trying to see that we do it as a clinically indicated. That has been the guidelines now. This kind of person, young age, although we may have a limited treatment for these patients, that what can you do with a LP little a? Lot of studies were presented in AHA, and a few therapies are ongoing at present. Dr. Rogensen at Sinai enrolling patients with high LP little a. So that actually remains.
Can I give retrograde dye so I
Okay.
know I'm in the...
You need to get some hydrophilic wire now, whether whisper or
Okay, then you have to go with the...
yeah.
No,
Since
no,
you
not
have this,
this one.
which one you want?
I'll get fielder itself.
On retrograde?
Okay, yes. The ostium probably has disease. You see that?
The total cholesterol is LDL is 73, total is 118. That's good.
Okay, get the fine cross.
Yeah. So basically, it will require little extra efforts now to go into the PDA, which
Yeah.
is very, very important. What happened to this wire? We took the wire out?
No, it's there. Keep the wire.
No, first
Take
go
it
with the
out, take it
fielder.
out.
Go with this
Get
wire
us a
first.
new fielder. No, we can use the run through if you want. This
Yeah.
run through.
Yep, here. We are going
And
back.
the Miracle 6 is there.
Yeah.
I think you need a stiffer wire. Ostium is probably total there.
Okay. Yeah,
So
so
now we
yeah.
tried just with the run through wire and a 2O balloon to see if we can get into the PDA. We could not. Now we are going back with a fine cross. And then I think we need a stiffer wire. So I'm going to try Miracle. Or you're saying try fielder.
Yeah, Miracle or Whisper? I'm voting for Whisper if you need to get a second wire. If this does not go, yeah.
Now why we are going back with a fine cross, so we can do multiple wire exchanges.
Yeah.
Are you holding the wire?
Just 1 second. Yeah. Good. You want to magnify
Okay. Okay, get the.
and get the retrograde. Go to little epicranial to see the ostium a little better. Yeah, good. And let's take a retrograde picture. Good retrograde picture. Okay. Sine.
This is asking for a miracle. Get
That's
the
fine.
miracle.
So we can do miracle is there.
Other thing is.
Yeah, very angulated PDA now. As you saw, it was there and that way anyway. Good. Got the miracle. Make a reshaping. So miracle 6 we had, but keep a whisper also nearby. Okay. So see that angle by the retrograde injection. Ready? We take this out. Keep this one run through. See that angle? The tight disease, distally, and then angle of the PDA. Definitely unfavorable morphology.
So I've placed the fine cross distal to the PDA. And then it's not making a good turn.
Actually see better with the retrograde, yeah.
Die there, yeah. Maybe, what is going on here? Okay, yeah. Okay, now, yes. Okay, can you take a cine?
Okay.
Injecting.
Your ostium is blocked, therefore means wire is in the right position. Remember now it is not coming back up to the ostium.
Should have gone though. Okay, get me a.
What do you need?
Get me a new Miracle 6. Yeah, that's not doing the job. Thinking.
So we are going back to the Miracle because the tip of the other one was a little more destroyed, was more angulated. You can see here. Now, we saw that earlier, filling up the PDA up to the ostium. See that? And now we did not. That means our wire is there at the ostium. See that? Yeah.
Occluding the,
Yeah.
maybe.
Yes. Throw
You have
it.
the confidence already?
I'll go with the whisper first.
Okay.
Anu, I don't know if viewers have appreciated this. It's something I've noticed often about you in particular. And strangely, till today, I didn't even emphasize on that. You know, as you're working, you're constantly, your mind is thinking about, so here you are, you're using the Miracle, and now you're already asking for the next wire. You know, it's such a excellent way to do it. Wonderful coordination with the team. That's how they save time. And often one feels all the wires are there. They go and grab it and open it only when you tell them. So very, very good practical strategy. And I've noticed it for years. I don't know why I never emphasized
run
it.
through. Huh? Or fielder. What you want?
Cine. You want Cine, right?
No, I didn't want. We know we are there.
Yeah. Or you want to just go with the run through now?
This is 300?
No, regular run through. You can go. What do you need now?
Yeah, I need another wire to exchange.
Okay, which wire?
300 has to be.
Another 3 run through. Yeah, it looks like the wire is a little subintimal.
No, it's going to a branch. You don't think so?
Okay, we got to run through now. You can throw it away. Good.
If there
No, why I was asking for my next wire is that I felt that at the ostium, though we the original
Keep a 2 balloon ready.
wire was there, which was Miracle 6, I thought could be subintimal, so I needed Confianza if I was subintimal to get into the lumen. Let's see how this wire behaves, otherwise we go with the Confianza. That's the thought process going on.
So it seems to be that we have gone into the part of the PDA. See that? But whether it's in the true lumen, it looks that way, but with after initial dissection, which is okay.
Now how we are going to stent it? Because there's a disease in the AV, and then there's PDA definitely will need a stent.
Yeah, so I think this is the case. We have 6 French. Once we are in true lumen after balloon dilatation, we go with a step crash.
Confianza to get into the lumen, right? Get the Confianza. Okay.
No, we may be okay now. Good, good, good.
Now hold on. Okay, let's take a picture.
Yeah, we are good. Yeah, 2 or 20 balloon.
Yeah.
Yeah, let's go to 2 or 20 now. Good.
Don't
Flora. Okay, so we got the retrieve our PDA.
Is can you ask Yulia come down?
Yeah. Yeah. Connect and go negative on this one. So we are going with a 2 or 20 balloon we had. We'll do a 2 or 20.
Why don't you want to do provisional?
Provisional in what way?
Into the PDA and just balloon the AV.
Okay, that's fine. Yeah.
Don't connect, please, like that.
No, but you have to go negative. This is a used balloon.
Go with the
used balloon.
How to do it. Use the syringe.
Good. Done. Okay, go. Do nothing now. We've gone negative. Yes. So we have to dilate the distal, and the concept of the provisional is okay too.
Because all depends
Good.
how we balloon.
Yeah.
Actually, we never ballooned the AV continuation also, so
Yet.
we're going to balloon the AV continuation now.
Okay, hold
Then
it.
we decide the stenting strategy. Get down.
Little distal and little proximal. Yeah, let me do it
Go
here.
proximal. I don't want to go distal. Let's take a picture, then only we go distal. Ready? Antegrade.
Yeah.
Now we're talking.
Yeah. Good. I think that's okay. Let's go AV continuation 2.520. Nice ballooning.
I think the guy who said that it was a easy CTO probably realized what it is now.
Yeah. Okay. So let's get the balloon strategy will be 2.5 16.
Do you
Or
think
20?
it's calcified?
No,
It
no.
is. No, hold on.
One second.
What is your stenting strategy there?
No, first we have to do a balloon of the AV continuation now and then put a stent across. And if it had to be, we to do a reverse crush.
If you do the okay.
Yep.
Okay, give 2.5.
Yeah.
Okay.
2.5. Yeah.
There's an expert CTO paper. Print that paper and expert CTO and the time required to cross the lesion.
So now our idea is that AV continuation PDA is more important. You saw that big vessel. Right, Samir? So we're doing a balloon of the AV continuation as a provisional. If need to be, we'll go through it and do the reverse crush. So right now we are doing a nice balloon dilatation of the AV continuation. Hold the wire.
Yeah, see it very nicely and
Yeah, big PDA. On long term, because remember, if patient goes for CABG, there was never a plan to put a bypass into the posterolateral. The plan was to put a bypass into the PDA. So as long as we can retrieve the PDA and get a great results, little suboptimal results of the AV continuation is fine.
Yeah, and plus the myocardium supplied by PDA is always larger. Okay, good. So this is the 2.5
Yeah.
into the
20.
2.5.
We want to get a good balloon results. Okay, I'm going up. So basically what we do is, this is a balloon trick. You go and inflate your pressure, whatever require your balloon inflation, then go down to half. Purpose there is that you have created a crack into the vessel of the intima, so balloon dilatation, and at a lower pressure, you are taking it up. If you continue high pressure, it will chances that it will dissect further. So basically go up 12 to 16 atmosphere and then go down to half and leave it for about 30 seconds and so. So with that note, let's go down.
Give me a pen.
And so wire came out, which is okay. Good. So we do an antegrade injection.
Which wire came out?
No, nothing. All good.
Don't touch it. Wait.
Yeah, here. Looks very good. There's little dissection at the ostium, which we expected. But so far, nice. AV continuation has plumped up with a lot of disease downstream, which is okay. So let's take this out and put a stent now.
Into the PDA.
Yeah, PDA. Stent will be in the PDA. Yeah, good. This comes out. Yeah. 2.5, what we have, 20? No, the stent.
2.5 or 2.75? I think 2.5.
2.5, 2.5,
Okay.
2.5.
And then proximally we put a 16, 3 or 3.5.
Yeah. 3 will be okay. And we'll leave the wire. A lot of people will say in this situation, you can even leave the balloon also. Yeah, ready? Okay, we are ready to put a stent now. 2.520 into the distal RCA going into the PDA. Now 6 French with a 2.5, 2.25, 2 stents can go also. If you want to try that, mini crush now. Nothing wrong in that. If you put a short 2.25, 12 in the AV continuation, let's see this goes very well. Keep going.
No, this is going to the PDA.
Yeah, this is the PDA, yes. I'm talking about the AV continuation because the ostium is still a little dissected. There was a disease to begin with. And with the 6 French, you can put a mini crush. Mini crush requires 7, but 2.25 and 2.52 can go through it. Let's put the wire back first.
Okay.
1 second, let's attach one before we take a picture.
I think it's good to show provisional
Dine?
stenting.
Want to pull back 1 millimeter?
Good, go.
Yeah, good. Ready? You want to put a second stent or no?
It has to be
Huh?
2.5.
Yeah, 2.25. 2.25, 12. Yeah, believe me, we'll go through the 6 French. Let's give it a try. Okay, we're doing a 6 mini crush through the 6 French.
It's not 12.
12. Yes, 12. Ostium, if need to be anything further, you can always do. But as long as the ostium is spared, so that will be the goal. If you have trouble advancing, then we come out. But if we can advance 2 of them, we go. 1 second.
Wait. I'm pulling it because it's.
Yeah. So our main, where the money is, the stent is in the right place. Now, can we get a second stent in the AV continuation? It's like a bonus. If we can get it, otherwise we can always do the step or reverse crush technique. Actually, it will be reverse crush if we need to go back into the AV continuation. Good. Keep seeing the fluoro because that's another important point. Your all equipment, wires, all will go further. Yeah, a lot of people don't believe that you can put a 2 stents, but trick is has to be 2.25 or 2.5, and sometimes even that may not go.
Yeah, nothing like seeing it in the case, and here we go.
Yeah. Going slowly. Yep. Coming. Good. Did it. 6 French. Okay. Good. Let's pull back the PDA.
It's the other way around. So AV first.
No, I know.
Crush.
Pull back the PDA into the position. PDA has moved further.
You mean the wire?
The PDA stent.
Yeah.
Stent, yeah.
Yeah.
But the thing is, I think, now you don't know which is what.
This is the PDA.
Yeah, they're good. Okay.
Okay, just let's take a picture. Looks good here. Yeah, AV want to bring back 1 millimeter, that's okay. But otherwise we'll okay also because we will open the kissing anyway. Good.
Wait. I'm breaking the AV now. That's AV.
Yep, going up.
This is the PDA. Yeah, go up with the AV.
Okay, good. 14, because it's a 2.25.
Go up.
Go to 16. Yeah.
Okay, down.
Just do a little further in massage of the distal AV. Go further because there's a lot of disease. Yeah. Sharma's massage. Good.
My hands don't work for these things.
Yeah. 2 atmosphere massage. Good. Pull back the balloon and our wire. Good. Okay. Ready? We're going to the AV continuation. Go.
No, the speed. Yeah, go.
I'm in PDA now. There's the PDA. It's a 2.520.
Down. Go up again.
Yeah.
Yeah, I need the results.
Pull back few millimeter. Good.
Okay, good. Down. Let us see.
Take both of them out because you'll not be able to inject right now. Keep the three ways.
Which wire is?
Both. That doesn't matter. Both are coming out.
No.
Yeah.
What is both coming out? Okay. Everything is coming out now.
Good. Throw them away. Get a little nitro.
Let this out. All this out. Wire. Let's take out one wire.
Okay. Good.
Oh.
Good. Take the guide out a little bit.
Okay.
Throw away the other wire.
No, we cannot take the guide
Get a
out.
little, little bit guide. Good.
Okay. Good.
Yep.
We give some nitro.
Yeah. Give one.
Get the fielder to recross.
Sinai. All right. Now we are talking. Look at that.
So we'll recross KISS. We'll put a actually the proximal lesion is looking better and better as we
So
keep
that's
giving
okay.
guide.
There was mild disease. We'll leave
I
that
think we'll
alone.
leave that alone. So we'll recross and KISS. You start your lecture right now.
Okay. Where is the fielder wire?
Anu,
Yeah.
looking very
We are
good.
two a balloon.
Yeah.
Yeah.
Not very
Yeah, we
good.
needed this mini crush,
Excellent.
otherwise would not be in that good results. You needed, but once you have such a diffuse dissection, yeah,
Look, 37-year-old, we need to get absolutely the best result possible.
beautiful, yes.
The
Tell them
2 or
rooms-
12 we had, right?
Yeah,
We
we are
can
2 or
use the
12,
same
yeah.
one.
We go that first and then we have 2 or, then we need a 2.5 actually.
We can go
15
2.5
also.
high pressure.
Yeah, 2.5 high pressure.
That we have.
2.5, 15 or 20. No, we don't have non-compliant. Yeah, good. So still that let's you show it before I go to my, because rest we
Nothing,
can show.
recross and
Right.
kiss you,
No, I know, but
you
look
don't
at the,
need to
no,
see.
but angiographically look at this one. So this is a great results happen because we did a mini crush through a 6 French guide catheter.
I don't think.
Very, very important. Tell them room 6 patients should just
I
wait
think,
outside till I come out. Yeah.
Most important is how we handle the CTO bifurcation.
Yeah, absolutely.
That needs final touch. When you finish your lecture, I will give you that.
Okay. So while you want to wait till you cross or what do you want to do? Okay. So people definitely want to see. The patient can come out, but wait outside. Yeah. Good.
Okay. That was the fielder wire we
Yeah.
crossed with. Give me a 2 or 12.
You're right here. Now, since we use the over the wire system, we should cut the run through.
No. It never goes easily.
Okay.
Waste time.
We made negative or no? Good, negative, good. So we
I don't
this is
think
the
we
used.
ever used it.
Which one? 2?
No. We used to recross the PDA and we never dilated it.
Dilate. Good.
Yeah, good.
Okay, get a 2.5 also.
We have a 2.5. Let's just use what we have.
No, we don't have 2.5 high pressure we need.
Yeah.
Non-compliant.
Yes, yes.
Non-compliant?
Yes.
Yeah.
We used
Yeah.
it.
Yeah, we use that 2.520. Yep. Good. Okay, so we are same. We're ready using just the existing balloons which we have used before. Yeah.
No picture. Don't need
Yeah.
it.
Good.
I know somebody is complimenting your result. Great, excellent result. I don't even know where the lesion was.
Yeah. Connect. Go negative.
The
Good. Let's put
definition
both of
of
them.
a good
Good. They're
angiographic
going up.
result in a PCI.
Yeah. Go both of them.
Okay, down. Okay, good, right?
Yeah.
We're done.
Very good. Take a picture. You'll do remaining mock.
Nothing.
No, just let me take a picture now.
I'm taking everything out.
Yeah, good.
Okay, vasodilators going in.
Right.
Pull
That'll.
the plump up the vessel. I'm going to get the guide out a little bit.
Yeah.
So
Good.
counter it. Okay.
Yeah.
Okay, ready?
Yep. All right. Wow. Now question will be that do you change the antiplatelet therapy to a little stronger one? There's no reason not to. We actually have a paper coming out.
What was the PRU?
No, PRU is good. PRU is good. But question is in this case, on a long term should benefit from, we actually have paper accepted. Our practice of to be the different P2Y12 and using in stable CAD of using a prasugrel or ticagrelor compared to clopidogrel. So found a little better outcome. It's coming out in JAK intervention has been accepted. Will be so our practice pattern in this kind of case, I would say, is the right thing to do. That is, we switch it to a more stronger antiplatelet therapy at this time. So this is the final picture we have. Excellent angiographic result of the bifurcation. Yeah. So overall, you want to say
You go.
contrast?
No, I will, yeah. What's the
150
contrast?
fluoro 25, air karma 2, DAV 157. So 150 contrast with the fluoro time of 25 in
And
this
an
complex.
air karma of just 2.
2.
We just made it. Yeah. Beyond 2 is
Now remember
right?
the PDA still have a little sluggish flow because there is a lot of microvascular disease. See that? So I would say this patient will benefit from a stronger P2I. So what would you do now? In this case, you give a 30 milligram loading dose, not 60 because patient already on clopidogrel, 30 milligram loading, and then we give 5 milligram. Now, if the weight is more than 100 kilo, this patient weight is less than 100 kilo. So 5 milligram daily. If it is more than 100 kilo, what is the weight now? Oh, so okay. So a patient will get 10 milligram daily now because of more than 100 kilo. Now, other question always comes that how long you need to continue 10. As you know, host exam and many other trials have shown that you can down escalate after 1 month or 3 months. So and longer you give, more bleeding occurs. So commonly we give from 1 to 3 months of your full 10 milligram and then down grade to a 5 milligram daily. So that has been the strategy. So this case will get 30 loading, 10 milligram daily. I would say probably 3 months, and after that go down to a 5 milligram prasugrel along with the baby aspirin. But excellent angiographic results. But there is still a lot of microvasculature, and that will help. So with that note, let's go to see that in the end there is still a little bit of diastasis in that area. Yeah. Anu, you want to say anything?
No, when you're done, we can say, what was the reason and what was the
No,
way we
complete
used it.
this one's better.
Oh,
Yeah.
okay.
But right
No,
now, I think
so-
all teaching
So
points
as soon
here.
as we cross the CTO, remember always the goal is the wire should go to one of the side branch. So if it had gone into the PDA, we'll take the PDA and handle the AV continuation later. But here it went into the AV continuation. So that's okay. You take one of the branches and like we did, you dilate and then see. So often you will see all the branches and this is what we always try to teach, that your entry has to be the proximal cap and your exit has to be the distal cap. That way all your branches are intact rather than cause dissection and re-entry and you lose many of the branches here. So every single branch we were able to keep here. So you saw us. So your CTO stopped at the crux, which is a PDA and AV continuation bifurcation. So we exited into the AV continuation. We were able to dilate. Now the question is the same, which we tried, that do we enter into the main branch, which is a PDA, before we stent. We tried doing that, and if we had persistently tried to go into the PDA, unlike the way we did, there was a lot of dissection and it would take a longer time and radiation and die. So that's why we said, okay, let's stent the proximal part, which we did, and then you can cross. So here, how important was the retrograde injection to place the stent? You want to make sure the PDA was not covered. That was only possible with retrograde injection. So retrograde injection placed a stent. Then how we were able to get into the branch was again with the help of the retrograde injection, and the same. I mean, just I used a stiffer wire because we thought that the ostium had disease, probably 95% or maybe 190 is a subtotal to 100% ostium. So we used a stiffer wire. If not, you wanted to try with the softer wire tip fielder whisper. With fielder we tried. If not, whisper also would be okay. Now same thing. Once we entered, if you think we are in the subintimal, then you go escalate there. So you are into the lumen of the PDA, and then of course balloon and keep both the branches intact. So going back to the point that it did not look like a CTO, that was very easy. We crossed. Expert CTO was a trial. We were the highest enroller and the first enroller that in that trial. In that trial, actually, all these wires that we discussed, pilot wire as well as progress 200 wires were tested. And in that, they always tested the time the guide wire exited the guide and when did you reach the distal vessel. So our center always beat the timing, and the timing was always less than 4 minutes.
Yep. All right, great. From expert CTO experience, the publication on the Jack intervention on that paper has been quite well. The CTO, as I said, the CTO definitely has the very challenging. Those who are a CTO expert or CTO make the life based on the CTO have a tough challenge based on our coronary revascularization guidelines of this year or December, published in January of this year. So we had to really justify it. So this case, now let's go through our points of the latest issues in coronary intervention and the trials, one of them from the TCT, two from AHA, Bright 4, Exit, ECMO CS. And the focus review of the month is impact of revascularization on low EF. So we know that recovered trial data we presented last month. So I'll say something different because change in EF with coronary revascularization and subsequent risk of adverse cardiovascular outcome. So basically our the three trials I'm going to discuss. One is the bivalvulotin Bright 4. This is the bivalvulotin plus high dose infusion. Now title was high dose infusion. It was confusing for some people because the dose was 1.75 milligram per kilogram per hour infusion. So that is the usual dose. Remember 0.75 milligram per kilogram bolus followed by 1.75 milligram per kilogram per hour. Of course, you decrease the dose based on the renal failure patient goes to half 1 or 0.25 or so. But key is this is the usual PCI dose. What they wanted to make sure that don't use the acute coronary dose is like QT dose 0.25 milligram per kilogram. So this is what we usually do. While patient getting a PCI, get 0.75 bolus and 1.75 milligram per kilogram per hour for 2 to 4 hours. So remember the earlier trial of the Horizons showed there was early stent thrombosis about 1% higher, despite there was a lower mortality at 30 days. And therefore, the purpose of the trial was that by giving extra infusion after the PCI for 2 to 4 hours, do you take away that stent thrombosis? I would say that probably is the most important point. And I know that bivalvulotin by various heat PCI and so trial had come under attack. That happened was as good as bivalvulotin. So this trial was done in China at multiple centers with the plan that what you do, because we have all the data on radial versus femoral, duration of bivalvulotin infusion, and by giving the high dose infusion for 2 to 4 hours against heparin monotherapy was really evaluated in this trial of 87 sites in China, which took about 2 years, 2.5 plus years to do a large number of patients, 6,000 plus cases. Very, very important. Large number of patients. Patients were randomized. Individual P2Y12, as you can see, 2/3 got ticagrelor, 1/3 got clopidogrel, which was equal in each group. And the remaining point was all comparable between two groups. But most important basically was they stuck to the principle that bivalvulotin group got bivalvulotin, and then infusion was given for 3 hours. Very important. So key is, this actually is the practice at Sinai. We maintained that many years ago when we saw this early stent thrombosis in the bivalvulotin. We never stopped in a clopidogrel naive or P2Y12 naive patients. If we give on the table, we always continue infusion for 2 to 4 hours in the past. And that is what coming back full circle now, that they gave 3 hours of infusion. And of course, 2B3A use was, as shown, little lower in the bivalvulotin group, little higher in the heparin group. Now, what were the results? Very dramatic. Death or bark type 3 to 5 bleeding, which is the significant bleeding, is decreased by 1.3%. So basically, number needed to treat is 76 to decrease one event of death or bleeding. And you say, well, maybe what does it mean? Look at the death. 3.9 to 3, almost 1% difference. Remember, 1% difference was also in horizons. So consistently same data. 30-day, 1% lower mortality with bivalvulotin. And bleeding, of course, also significantly reduced the high bleeding, which is shown here. These are the individual. Majority of them were with the excess site bleeding was 4.2 versus 0. Remember, majority of these cases are done by radial. So most of the event occurred basically in the non-excess site bleeding and so. So now what about the reinfarction and stent thrombosis? Very important. No difference in reinfarction, but more important, stent thrombosis. Remember, it was 1% higher stent thrombosis in the Horizon trial when you stop the infusion after the MI. So now you continue the infusion, you can see stent thrombosis now has taken another way around. That lower stent thrombosis of 0.4% in the bivalvulotin group compared to 1.1 in the heparin monotherapy group. So that led to the overall Mackey and Nace significantly favoring bivalvulotin. And these are the individual, as you can see, stent thrombosis, bark, the overall bleeding was trended, but most important, significant bleeding, stent thrombosis, all favored bivalvulotin. And the life, I would say, in our interventional cardiology is full circle, that in patients with STEMI, undergoing primary PCI, predominantly with radial artery access, anticoagulation with bivalvulotin plus a post-PCI high-dose infusion for 2 to 4 hours, significantly reduce the 30-day composite rate of all-cause mortality or bark type 3 to 5 major bleeding compared with monotherapy. So this is a nice editorial. It's basically showing that all the time when we have a lower anti-thrombotic issues, we have higher stent thrombosis, which decrease the bleeding. But this is the first time now we have shown both lower thrombosis and lower bleeding. So I think this will, whether it will come back bivalvulotin in our acute MI, need to be seen. But definitely we have very strong data from Bright 4 from China. Now,
Look,
second,
you can, Samin, almost overlap the Horizons presentation 10 years later with Bright 4.
Right.
Exactly the same, except of course in the methodology with the radial axis.
Right, and stent thrombosis, just put a heparin stent thrombosis up and down.
Right.
The key was, so exactly the same way what we noted, 1% mortality difference, everything in favor of bivalvulotin, except the stent thrombosis was higher, and now reverse here, and of course the radial, quite a bit, radial was very small. Now, second was this trial called Exit Calc study in patients with severely calcified lesion. So they identified based on the OCT first, had to have 4 score based on the maximum calcium angle of 180, calcium thickness of more than 0.5, length of more than 5 millimeter. So if calcium score was 4, patients were randomized to balloon angioplasty or IVL to see stent expansion. So that was the primary endpoint of the trial. That after OCT run, patient has the OCT score, a calcium score of 4, then you do a IVL or balloon angioplasty, then you do stenting. So IVS was done both baseline, after procedure device, and then final run. And those were the OCT endpoints. So these are normal, no difference, basically small study, about 40 patients. But there are a few things were important. One is the pressure. Remember with the little IVL, pressure was 5 compared to conventional was 16 atmosphere. That's one difference. And of course, the overall balloon size and balloon diameters was not different post-procedure, but little, I would say to our disappointment, that stent expansion was identical in both, 84 versus 82. in both the groups, where the conventional angioplasty, balloon angioplasty versus IVL. There was no procedural complication at in these cases at 30 days. Now, we say, well, stent expansion one. What about basically the stent area? And you see stent area was also minimum stent area MSA was identical between two. We definitely saw less dissection in the IVL group and higher calcium fracture. So you definitely cause the higher calcium fracture with the IVL, but definitely no difference in the stent expansion and so. So that basically showed that in this small study, there's no difference in terms of stent expansion. This actually at the heel, which I showed of the another study, which was the meta-analysis last month, that using rotational atherectomy, modified balloon or super high pressure balloon, that stent expansion was identical in the three groups as shown there. So it seems to be that if you can open the lesion, whatever technique it is, it does not matter. But the key is that you are able to have a device there, and many times you may not be able to get the device delivered unless it's a you had to do a atherectomy in some cases. Now, the third study.
Could it be related also to the size of the vessel?
Yeah, so this is the case. Of the average size was 3+ millimeters. So they have a straightforward vessels where you can deliver directly the IVL. As you saw, that IVL was delivered in all cases. So this was not those complex cases, angulated, tortuous, where you need to do a pre-dilatation. So they delivered IVL directly in all cases. So these were selected cases where you know that IVL could go directly. But that definitely is one of the important factors. The third trial is the ECMO cardiogenic shock. So always we talk about, there are a lot of data now putting an ECMO in the ambulance or in the emergency room before patient come to the cath lab or for subsequent treatment or getting cooling, which is an ECMO cardiogenic shock trial, ECMO CS. So basically the concept was, should you do early immediate ECMO or you do early conservative therapy, and then if you need ECMO, that is fine. So these are basically the whole concept was in this trial, and then downstream you can use an ECMO in early conservative if there is a parameter particularly high rising lactate. Primary endpoint was death from cause, resuscitated circulatory arrest, and implementation of another mechanical circulatory device at 30 days. So this is basically was the trial. A small number of cases, took them 8 years to do this 120 patients, but these are the tough patients, as we all know, in the cardiogenic shock arena. But our outcome were no different. Whether you did ECMO early or in about 40% of cases in the conservative arm, you did ECMO because of the rising lactate later, there was no difference in the primary outcome or the death from any cause. So just to say that even this day and age, the latest data, there is still the mortality, as you can see, about 70% mortality of the cardiogenic shock. This is a refractory cardiogenic shock at 30 days. And mortality, as you see, is the 50% in two groups. Now, downstream ECMO is required in about 40% in the conservative group. There is upside. The issue basically was that ECMO you did initially was associated, trended towards, I would say, little higher bleeding, leg ischemia and stroke. Why? Because many of these cases probably didn't need it. So that's basically was the downside. Did not make a statistical significance, but numerically quite different in the serious adverse event, as you can see there. Now, these are the then rapidly deteriorating advanced cardiogenic shock based on the SCAI definition. That initial ECMO was slightly better, but overall death from any cause, as we saw, there was no difference. So basically, trial concluded that immediate implementation of ECMO in patients with rapidly deteriorating or severe cardiogenic shock did not improve clinical outcomes compared with an early conservative strategy that permitted downstream use of ECMO. So key is very important that this group of patients are still challenging, and we need to continue to do our better job. Lastly, the focus of review of the month is impact of revascularization on low EF. The change in LVF with coronary revascularization and subsequent risk for adverse cardiovascular event. Paper published in Circulation Intervention, and basically from the Boston VA system, patients more than 65 years of age who had one, EF less than 50%. Second, they have the EF measured before and after revascularization, whether they have PCI or CABG. So this is basically a final cohort of 10,000 patients, large number of patients, and they have 5 delta categories of EF. One, EF went down by -5. It went down between -5 to 0. Or third category was EF was 0, no change. Fourth category, EF improved but less than 5%. And last category was EF improved by more than 5%. So you see that the variety of the EF improvement, and these are the delta EF in all these patients. But this puts it together. Whether PCI or CABG, you can see group, almost 50% of patients will have a EF improvement from anywhere between 0 to 5 or more than 5%. So that's a good thing. Have a EF improvement as shown by the CABG and PCI. The others are equal, as you can show here. Then these are the overall the categories wise. These patients were not much different. Minor differences in the patients because this was not a randomized. This was all the PCI and CABG stratum, and this actually it puts it together. So basically, overall, the mortality crude event rate was 11.48%, and heart failure hospitalization days were 96 days in the entire group. Now, if you take it to the PCI group, so this was 12 versus 105, and in the CABG group was 8.8 versus 69. So basically, both have improvement, as I said, 50% ejection fraction, but these are the follow-up. Now we wanted to see whether there was any impact of improvement in EF with these PCI, the mortality or heart failure hospitalization in both the groups. So this is very interesting. So let's go to one, mortality. The overall mortality are shown here. When your EF goes up, your mortality goes down from 12.7 to 9.4. Now you take into the PCI group, you can see individual increase in PCI. Going to the right side of the yellow bar, that mortality goes down compared to if EF did not increase or went down. Now in the CABG stratum, you can see there is a horizontal line. So what does it mean? That overall 5% improvement in EF decreased death by 5%. In the PCI group, 5% improvement in EF decreased 6% death. In the CABG group, there was no effect delta. Second, heart failure rehospitalization. You can see on the top, increasing ejection fraction, lower heart failure hospitalization. Now PCI, again, increasing EF, bar of the yellow, height of the yellow bars, decreasing heart failure hospitalization. You go to the CABG group, there is a very chaotic, no difference. So conclusion basically was, in the CABG group, 5% improvement in EF, no significant change in heart failure days, compared to in the PCI group, there was a 10% decrease in the heart failure hospitalization days. So this basically concluded the revascularization associated EF improvement was associated with significant reduction in mortality, heart failure hospitalization burden, particularly in the PCI group. And this comes on the heel of basically nice editorial of our revived BCS2 trial, where there was no difference in EF after PCI, no difference in overall mortality at 5+ years. So still, this field continues to evolve. So let me just complete it. Take home message of our intervention trial and change in EF. Basically, bivalent with high dose infusion STEMI, 3 thumbs up. After a long time, we had a very, very positive trial. Second, IVL versus non-compliant balloon angioplasty for stent expansion, calcific lesion. No benefit, rather except subtle benefit of lower dissections. Then immediate ECMO versus early invasive stabilization, delayed ECMO, cardiogenic shock, no benefit. And then coronary artery revascularization, PCI or CABG in patients with low EF has variable response of improvement and its impact on subsequent death and heart facial hospitalization at follow-up. While CABG is routinely favored in these patient subset, current registry study showed that improvement in EF after PCI was significantly associated with reduction in mortality and heart failure hospitalization, while there was no clear-cut correlation after CABG in these elderly patient subset. So quickly, 3 questions. Following is the true statement of the BRIGHT 4 trial comparing bivalent versus heparin in STEMI PCI at 30 days, except bivalent group had lower mortality, bivalent group had lower bleeding, bivalent group had lower MACE and NACE, bivalent group had slightly higher stent thrombosis, bivalent group had similar reinfarction. Answer is not a high thrombosis, rather significantly lower stent thrombosis. So this was the wrong. The following statement is false regarding the results of the EXIT calcium trial. comparing IVL versus balloon angioplasty in calcific lesions, similar MSA post PCI, similar stent expansion, similar MACE, higher edge dissection after IVL versus balloon angioplasty group, and similar calcium fracture after IVL. Clearly, the edge dissections were lower in there. Lastly, following statement is false regarding the impact of coronary revascularization on LVEF change in heart failure hospitalization after PCI versus CABG in patient with low EF. Both PCI and CABG are associated with the rise in EF. 5% rise in LVEF is associated with 5% reduction in death. 5% rise associated with 10% reduction in heart failure hospitalization. Impact of LVEF improvement was similar in both CABG and PCI group, and there was gradient with delta change in EF improvement and corresponding reduction in death and heart failure hospitalization. Clearly, the answer is D is a false, because there was the LVEF improvement translated into a better outcome after PCI compared to CABG. And with that note, I conclude my didactic presentation.
Samin, excellent presentation. The relevance of the ones with the ejection fraction is actually absolutely a pivotal trial. Whichever modality we use, PCI, CABG, the end of the day, you improve the ejection fraction, the mortality will continuously decrease. Anu, final comments from you. And Samin, you're joining me here in the control room for our presentation on Medstream 360, for which I have already announced that Dr. Stone would also be joining us in a couple of minutes.
And you want?
No, I think we are good unless there are any questions.
Yes, Anu, some of the questions related to that, what would have been your strategy if you were not able to cross with the support catheters, and even back and forth they are going with the strategies, that what would have been your strategies with the different wire. I have referred all of them to the app, that almost all the case it's highlighted in the apps, the wire escalation strategies, and so overall generally
Can you ask the questions? What are they asking?
The one question was, if you could not cross, what would you use?
Okay, what is the
strategy?
right? I'll read the exact one. What is the strategy to use if micro catheter would not have crossed?
Yeah, we had already the laser already here. So if the micro catheter did not cross, there are two things that you can do. One, you will take out the micro catheter. To remove the micro catheter, you have to do wire trapping. So you will put a 2.5 balloon side by side, and you get your micro catheter to the arch area, and then you will wire trap with the 2.5 balloon, remove the micro catheter, and then you go ahead with guide extension, whether it is Godzilla or anything else, and then with the 1.0 balloon, 1.5 2 balloon, any of this you can try. If they do not go, you will have your Godzilla there with the guide, and you can have the laser. Now we know we can use a laser here since our movement of the wire was very free, and we knew that the way we went, there was no way there was any subintimal track or dissection that we have created. If we are not sure that when we are wiring, how the wire went through, that if it has gone through subintimal track and then made a re-entry later on, try not to avoid laser. There's a risk of perforation with laser. So question same, that if the micro catheter would not cross, you go with the smaller balloon. If that don't work, go with the laser. And in real situations, if it really the laser also does not do it, go back with the micro catheter, and we will try to wire with the rotor wire as long as the micro catheter tip is very close somewhere to the exit point of the CTO, and we can do a 1.25 bar.
Beautiful, good. And we can show the last slide of our Medstream. So that will be our discussion now. So we'll join there now and have a discussion. I'll join you in 2 minutes.
This is really going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
for Medstream 360, we'll be extending 24-hour live cases so that you can watch cases in your own time zone, time frame at your own convenience.
Medstream 360 is a transformation in medical education. With Medstream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of Medstream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make Medstream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field, and the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to Medstream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.
So we are continuing here with our viewers on our concluded 161st consecutive case of CCC live cases. Happy to invite Greg. Greg, nice seeing you. I hope you watched some parts of the case too.
Hi, Samir and Samin. Great to see you both, and fantastic case.
And more important, the Bright 4, the PI of the Bright 4. I said, bifurcation, taking the second breath now and coming back in full circle.
It's the results are very clear. We have to implement this at Sinai immediately.
Excellent. Greg, we will devote the next few minutes on talking about Medstream 360. And all of this got precipitated by a flurry of questions and huge interest which we have gotten. There are people who have sought more information, people who want more details, people who want to understand exactly how this is going to transform. So the first comment I want you to make is that several people have asked, how is this going to be changing interventional cardiology?
Well, I think that the concept of Medstream 360 is that it takes the, unique information that you get from live cases that usually is only present at courses that are done for a couple days here and there. And then for the most part, those cases get archived somewhere and it's not easy to ever pull them up again. To basically a 24/7, 365 day a year experience, where there's always a case going on, whatever time zone you're in, whether it's before your breakfast, whether it's during your morning or lunch break, whether it's after work, if you're being driven home, or when you've got an hour in the evening, you can just tune in and see what's going on live from some of the best operators in the world. And then I think even more importantly, and what's going to be most useful, is that we're going to do up to 9,000 cases a year. And there'll be every kind of case done, from simple to complex case, using every kind of device by, again, hundreds of operators. and you'll be able to search these cases. So if you want to see the use, for example, of a specific hemodynamic support device in high-risk PCI, you can pull up 10 of those types of cases. If you want to see Samin Sharma's rotational atherectomy technique, you could pull up 5 cases that he's done with that. If you want to see the, a specific operator, specific devices, specific types of cases, thrombus and acute coronary syndromes, how do different operators manage that? You can pull up a collection of those cases. So the archive case will be relatable and fully searchable, and I think is going to be a very, very valuable resource. So we're very excited about basically transitioning from the static intermittent live case course experience to a continual 724 365 day a year opportunity, which is not going to replace, by the way, live cases. I mean, live cases, I should mention, they're so well organized, they're very well moderated, and you don't usually get to see the whole case from beginning to end. You get to see the highlights of the case. They're usually the operator's best case or the most complex case. There's a great role for that, and that's always going to exist. This is going to be more the everyday case from beginning to end, with lots of different operators, lots of different devices, lots of different ways to do the same procedure. So I think they're going to be very complementary to each other.
Greg, I'm glad you even mentioned about it's complementing the existing live case format at large meetings. That was I have it here as the third question, so I'm glad that is also out of the way. Samin, your thoughts on this transforming, and specifically there is a question which also came for you, is this a larger global CCC live cases endeavor?
Well, I'm clearly the way our format will be that as Greg just mentioned, that 24-hour compared to the sporadic 1 hour the presentation in a week or in a month. So key was that even in the past, so a lot of people when we used to visit various meetings, they used to ask that why can't we do a case in our time format? So sitting in Australia, in Germany, in China, India. So this actually, I would say the Medstream 360 will be the full scale of live cases present in their own time zone, done in their own comfort. So this is where I would say the extension will be, but concept definitely we originated, and we'll try to keep a similar type of the format, and then how we will implement operationally of the CCS Live, knowing the success of CCS Live, which have been great, almost 18,000 plus participants per month in 170 plus countries. So it had been a huge success. But this now will extrapolate, expand further to the new dimensions. And biggest importance of that dimension is that ability to see cases in their own time zone, in their own comfort of their home, their driving, their office, and so on and so forth.
Completely understand. And Greg, another question which has come, which I can actually answer both these about the logistics. The important part is that the cases are being done during your normal operating hours. So no cath lab is going to be asked to be doing a case at midnight or something, which I've seen Samin come here at 4 in the morning to do a live transmission to India. So from the sites, the transmission is happening between, actually the times are 9 to 5. Bankers hours, perfectly. They are completely comfortable. You don't have to inconvenience a patient, and the recording is viewed 24 hours a day. That's how it works. The next question which comes is, what have we perceived would be the distribution of the cases? So we've done some research on that. And to begin with, we believe that about half, actually the exact number is 48% of the cases will be coronary, 39% would be structural, 12% would be endovascular. But Greg, I am sure even you perceive this to be changing in the future.
Yeah, I mean, the one thing about interventional cardiology in its history is that it's never static. And now PCI is for a large part a mature subspecialty, although we're doing more and more chip cases, the complex high-risk indicated patients, and obviously CTOs have become its own subspecialty. So I'm sure a lot of those cases will be featured. We've got to be able to deal with calcification. We've got to deal with bifurcation lesions. And of course, left mains are being done more and more. So you're going to see a lot of that. But then a lot of the growth and a lot of the new devices was obviously is in structural heart. First valves, then left atrial appendage closure, PFO closure. Now there's going to be interatrial, septal devices for heart failure and a whole new series of heart failure therapies that are being developed. So it's a very exciting time. And I think you'll see, again, everything ranging from new devices to very well-established procedures where we're fine-tuning and honing the technique.
So it didn't stop there. There are also many anxious and very nervous people out there. They are wondering, how much is it going to cost them? So they are already asking us, is there a subscription fee? Greg, nothing of the sort at the moment, no?
No, I mean, right now it's kind of like YouTube. It's free for everybody. And it's again, our whole goal here is to enhance interventional vascular education. And the best way to do that, as long as we can afford to continue to do it, is to make it free. Currently set up as a not-for-profit. And so we're working very hard, working with our industry partners and others to be able to fund this so we can bring you, again, the whole spectrum of what is become interventional cardiology.
And of course, we'll be releasing, making our website available for registration soon so that people can begin registering. Several questions have come about that. Can we ask, can we watch these cases later? Of course you can. In fact, our work at CCC Live Cases over the last 15 years demonstrates that overwhelming majority of the cases are watched archived. And but Medstream 360 is not just only going to be showing you just an archived case which you had seen before. There has been a very deliberate strategy to customize it. Greg, you want to expand more on that?
Right. Well, that's really important because most people, don't have the luxury of sitting down to watch an hour or an hour and a half case. So they like it in more digestible segments. So you'll be able to have the option of being able to have an entire long case or a kind of an intermediate length, and you'll give us, Samir, the exact lengths, whether it's 5 or 10 minutes, and then a very short, snackable bite of just the highlights, just the snippets of the case, which will be on the order of a minute or two. So give us the durations that have finally been settled on.
More than the duration, let me also tell you how we have done it. So there are 52 dedicated physician video editors who have been practicing different formats for the last 14 months. Initially, when we started doing it, and what we did is that we've been testing the audience through gradual release on CCC Live Cases, and we tried to format it initially, converting a 60-minute case into a 30-minute case, which was actually quite easy because what we used to do was we eliminated Dr. Sharma's didactic presentation and the case became purely a teaching technical case. And we realized that it was good, but not optimal. Then we realized that the exact optimal duration is 20 minutes. So one of the things what we are going to do on the website, you'll have an option to watch the case in its entirety, absolutely no edits whatsoever. And then you have the next edited version of 20 minutes, which I'm willing to bet will be the most popular. Now, you have to realize that we are also planning to do weekend webinars in which there are planned 12 webinars and each webinar, each segment will be 60 minutes. And we plan to review 3 best teaching cases. So for that, we are converting a 60-minute video into a 5-minute because a 5-minute video should be the exact. So what we have been doing is testing all this. Now, the real expert in broadcasting this and to interact with social media, who's been greatly involved with Medstream 360 has been Dr. Mike Gibson. And he introduced to us the concept that you need to be having this snackable for the 2022 audience on Twitter. So we have a 55-second releasing of the case, which will be done before and after the case to bring in the audience. And more recently, we have also figured out that what we are going to distribute on social media several times a day to announce particularly what we are going to do is a 15-second, almost like a trailer. So all these different formats are there, trying to customize what people would like to watch.
So we have
And then
15 seconds, we have 55 seconds, we have 5 minutes, we have 20 minutes, and we have unedited. And you mentioned it, but it's a huge amount of work. Edit these cases to keep essence and the highlights of the case. And as you mentioned, you've got a team of more than 50 people, professionals that are doing this work. And that's why I think this is so unique, and it's not going to be replicated anywhere else.
So almost 2.5 years ago, Greg, when we started this journey, when you joined this endeavor and made it so much more intellectually vibrant, the concept was that we realized right away that we needed an assembly line manufacturing for these archived cases. And of course, we've done this effort, and only time will show. We'll continue to modify it. I mean, you have to realize that if you watch how something like Netflix is able to customize it based on some artificial intelligence tools, it can be done to your viewing preference, and we'll see. Many questions have come, and this is where I want Samin to put in his thoughts. Greg, yours also. What kind of cases are going to be shown? Are we instructing the sites what they have to be doing? And of course, the next question, which is going to lead into it, is also going to be the fact that almost all the sites have been left alone. It is their case. They choose what they want to do. We have even eliminated a distraction of a moderator so that the case comes through all its the fine teaching points from the site. But going back to specifically the selection of the cases, Samin, you want to start with that? We are going to be following in the announcement and the choice of cases, a strategy fairly similar to what we have used here for 15 years, no?
Yeah, so no, clearly. So I want to complete on the viewer timing when the viewers want to see. And we actually did the work, as Samir, you are aware, in our CCC Live. We took the poll of the people, and it turns out to be, like the students, or I would say fellows, the residents, they want to probably see entire, because they need to get both didactic as well as the cases. The faculty, the operators, interventionalists who are already in practice, they just want to see the practical aspect, the technical aspect. So that coming down to those 20 minutes, and that is where has become in many of the meetings, the live in box case. Usually it's a 20-minute session that you present that case of 20, and we have made quite a bit in the past. We'll continue to make the, further progress on this. So every case will become, from the archive point of view, 20 minutes besides the full case, and then of course in small bits which will be used for various other points. Now, second question is very important one, because that is what every site is interested. What type of case? Our goal is very simple. We don't want to make it a complex kind of case which we are waiting for entire month to do it one time. So it is your day-to-day case. So you have 5-6 cases, but one which has an educational value. Moderately complex. We don't want to be heroic, tough case, but case moderately complex, but with the teaching points. So, and that make it a 3-sentence summary with one video clip of the pre-case. So I think the format will be the similar way for the CCC Live. Here we do a little bigger description of the case, and we make a 2 video clips, but maybe just a 1 video clip or just a static image, but about a 2 or 3 liner of the case, because people interests are different. Some people want to just see the calcific lesions. Someone wants to see only the CTOs. So based on that, each site. So once you make that announcement, so I would say the audience will be better prepared. So that announcement has to go as an e-blast of that could be your, whether 55 seconds or 1 minute announcement with the Twitter or so. But we need to make the announcement of the case very brief announcement, so that way you'll draw more audience, more interesting the participants to their focused interest once they know which type of case will be shown at what time.
Greg, what do you think an audience can expect to watch?
Well, again, we talked about the full spectrum of cases, both coronary, structural, and endovascular. But what I'm excited about is the different types of approaches that you're going to see to similar type of disease. So, what's nice here is you're going to have cases from around the world. So the way they do cases in Europe or Latin America or Asia is going to be different than the United States and different from each other. So you'll see cases of intermediate lesions, right, with 60 or 70% stenoses, and some people are just going to stent it. Other people are going to evaluate it with intravascular imaging. Other people are going to use, FFR, IFR, or other non-hyperemic modalities. How are people going to deal with it when you're really convinced it's a significant lesion, but the IFR comes out non-significant? What do they do then? So you're going to see all these different approaches, and I think that's very valuable because people tend to train in the same institution, and you only learn the way it's done one way. And I, in my education, every 3 or 4 years, pretty much, I went somewhere different. And so I kind of learned from a lot of experts at a lot of different places and then found my own strategy in my own way. And I think through Medstream, you're going to be able to see how the similar types of cases are done by different experts in their day-to-day practice. And then that's going to help you develop your own approach.
So several other questions, and of course, as people come to know about it, they ask. They've been wondering what else are things different. So I just want to relate, Greg, from my interaction. So far over the last 2 years, I have spoken to 132 sites which we were considering. There would be 60 sites which will be taking it through 24/7. Initially, we are starting every Wednesday with 12 sites. I'll tell you what these sites are. But as we understood it more and more, so there are 3 very notable changes, and I want both Samin and Greg to also comment on that. First one is that we do not want a rushed operator. So you're not going to be getting 20 minutes to complete a case. No, we can watch the entire case. There are no time constraints. Of course, sites need to start in time because, otherwise you don't want an empty screen there. And of course, if the case goes longer, we have various possibilities to view it later. The second thing is that these are all top operators. We also don't want to distract them. So there is no external moderator. There is a third operator, or what we call as a communicator, who will be describing what exactly is happening. And the third part is we also don't want a gagged operator. We want the operator, just like how Dr. Stone just mentioned, a case being done in different parts of the world. They have different approaches. We have no issues also if somebody wants to talk about the cost of devices or compare devices. So nobody's going to be gagged. No operator is going to be rushed, and they will not be distracted. Greg and Samin, your thoughts on any of these and the value and why we decided it?
Yeah, I mean, I think these are all great points, and it's going to be very unique. And we're not directing operators what kind of cases they should do. We're not giving them any sort of suggestions as to what devices they should use. As you know, in many cases, you can use any guide wire, but in some cases, specific guide wires will give you advantages. And we're going to talk about what those specific guide wires are and why the operator chose, that particular approach. And so I think that letting the operator do what he or she normally does, okay, and work through problems and hear what the indications were for the case, why they're doing the case, always very, very important, what they're trying to do to minimize complications, and how they're approaching the case to, balance effectiveness versus safety and their own choice of their techniques, the devices that they used, et cetera, how they're going to follow up the patients. It's going to be an incredibly rich experience of learning, again, that I think will go to the life cycle of the patient. It'll extend beyond the cath lab as well. And we'll also, by the way, do follow-ups. So you'll see, as we start doing more and more cases, we'll bring patients back. And and in the normal course of their clinical outcomes. And we'll cover some of that on the weekend shows as well.
No, and that's a very important point. So the key is, as Samir had mentioned, emphasized, that case will be decided and will be done the way the operators have been doing, and there is no moderation. So there will be a third person to facilitate, because the questions will be asked by the audience. So they'll have an iPad. will ask that question to the operator and will be answered as necessary, as needed and in the time course of the case. So what we will ask our operators first, when they make the case presentation in first 1 or 2 minutes, tell us the strategy, what you are going to do. And then at 1 hour, wrap it up. So what was done exactly the way it's supposed to be, or if they deviated, what led to deviation and what the results were in the end. And lastly, as Greg mentioned, what is the antiplatelet therapy? Because that question keeps coming back all the time. Equally important, just doing the procedure, that how this patient will be followed. And most important is from the antiplatelet, antithrombotic therapy post-procedure will be also 1 or 2 sentences at end of the conclusion of the case. We'll ask the operator to make it. So idea there is give it the full spectrum of not only just the procedure. One, you committed, that's what you wanted to do, but you deviated for various reasons, which you know, simple case may become a little complex, but you deviated for what reason, and then wrap it up at end of the case, concluding remarks with subsequent importance on the antiplatelet antithrombotic therapy post PCI and subsequent follow-up.
With the intent being always to emphasize on education, education, education. These are all teaching cases. We want a global series of experts to demonstrate to a global audience what their approach is. The last area, Greg, I'm going to answer, but of course, I welcome both your comments as well as Samin's. People have asked about what are the sites which we have selected for the initial pilot, which is going to be a 3-month pilot. Beginning, we'll come out with the exact date. We are planning it in early January. At the moment, to give you an absolute global perspective, to have a 24 hours, this is how we have decided. There are going to be 4 sites in Asia, and we have actually done a great amount of analysis. Where exactly is PCI being done? Where is it being viewed? Which are the countries where the largest numbers are? So there are going to be 2 centers in Nanjing and Harbin in China, including Dr. Shaolin Chen. There are going to be 2 sites in India, one in New Delhi at Medanta Hospital, and then at the excellent Madras Medical Mission with Ajit Mulaseri. We then move to Europe and have 4 sites in Europe, which are in Copenhagen in Denmark with Dr. Lars Sondergaard, with the Thomas Modine in Bordeaux, France. We are looking at a site in Madrid, and there is also the exceptional site with Dr. David Hildick-Smith in Brighton, England. We then move to the Americas, and there is one spot which we are still trying to decide, but the 5 sites at the moment, which we are considering, 5, possibly even 6 at the moment. There has been renewed interest from several sites to be a part of it. We will be deciding between Montreal Heart Institute, between Amir Kaki in Michigan, with Cybel Carr in California, and then going down all the way to of course, a possibility of a site in Miami, and then to Buenos Aires and Sao Paulo with Dante Passaneses. So absolute, a complete distribution of sites across the world, and hopefully that will give viewers a global experience.
Yeah, no, it's extraordinary. And this is just Wednesday. This is just the pilot. This is just 1 day a week. Imagine when this is 5 days a week.
Absolutely.
No, it's a tremendous exercise which Samir has put together with the clock timings of individual, taken all the accounts which we have spoken in the time frame of their own comfort zone, and putting this together. I mean, it looks very exciting. And of course, we are time, I would say, after the years of preparation. One of the days in whether it's the 1st or 2nd week of January, we'll do the test pilot. The goal there of the pilot for first 3 months is, because we know that anytime you do a new, there will be a lot of issues will come up, logistically, operationally, equipment issues. So many things, those will happen. So idea was to not to start as all 5 days, just do a 1 day as a pilot. And after 3 months, with the success of the program, then we keep adding 1 additional day. So may take entire 2023 to get to the full 5 days, but definitely start with the 1 day of which is a Wednesday of January. So time is ready, and a lot of preparation has gone into and tremendous effort by Dr. Samir Mehta. He has done such a great job. Keeping all the personalities and all the issues of various centers globally and the interventionalists, so all that keep in mind, and very humbly created this very succinct expert team and the expert centers to be the part of or the pilot phase of Medstream. I really congratulate Samir on that excellent work he has done.
That's awfully kind of you, but I can tell you this has been a tremendous amount of teamwork. I simply cannot thank Dr. Stone enough. When I discuss this, I'm being very, very candid and open here. When I first reviewed this with Samin a little more than 2 years ago, of course, I'd been thinking about this for 15 years. I've been coming here. You think each time I was sitting here and doing it 8 years ago when we were doing simultaneous translation in Mandarin and Spanish. This was the model where we were headed. When we were a part of the American College of Cardiology, this is where we were going. So I'm delighted. But one of the things I mentioned to Samin is that I would not even think of getting into it till Dr. Stone joins us. So Greg, to you goes a lot of credit. And there is not, you've been doing this for 30 years. Again, I think in the total volume of cases, CCC live cases is way ahead of everybody else. So to have you give us your expertise, to share your brilliance, and of course, this is nowhere done. I also want to thank many other people in the journey. Ron Waxman at CRT has been instrumental. This is going to continue to have a large amount of presence with their methodology, with some ways in their meeting. And also, I want to thank Paul Tierstein, Mike Gibson, of course, I mentioned before. So many people to thank here, and we look forward to continuing to provide you updated information. The next logistic important point will be when you can begin registering. And Greg and Samin, thank you so much for joining us, and look forward to updating you all. Thank you so much, and we conclude our session. We'll see you on December 20th for our next website.
Great.
Bye-bye.
Going to be a unique platform. People will be able to tune in and see interventional live cardiology cases from around the world performed by some of the world's best operators. The real advantage of this is that they'll do 9,000 cases spanning the whole spectrum of interventional cardiology.
For Medstream 360, we'll be extending 24-hour live cases, so that you can watch cases in your own time zone, time frame at your own convenience.
Medstream 360 is a transformation in medical education. With Medstream 360, you can see wherever you are, in your office, at home, in your computer, in your iPhone or your laptop or your iPad, any case in any topic whenever you want. And not only that, you'll be able to see the best operators from around the world sharing their live cases with you.
There are several unique attributes of Medstream 360. We have no moderation and there is no time restriction. The majority of the cases, an overwhelming majority of the cases, are viewed not live but archived cases. So to enhance your viewing experience and to customize the archived cases to your requirement, we have assembled an army of physician video editors who have been experimenting with different formats. All of this is being done to enhance your experience and to make Medstream the most beneficial.
Concept here is to provide easy access to more live demonstration cases to more physicians. I think live demonstration cases are probably the best way to learn the nuances of our field. And the more we can do to bring cases of interest to our community, the better we'll all be. This is a great way to exchange information and to keep up with the latest in interventional cardiology, period.
So I look forward to welcoming you to Medstream 360, and please give us your feedback. We hope you enjoy it as much as we're enjoying putting it together. Thanks very much.